Welcome to Be Empowered, the podcast. This is a podcast where we dive into the realities of healthcare and entrepreneurship. We offer our opinion, unfiltered, unapologetic, and always with a dose of empowerment. We're here to amplify voices, both yours and ours, challenge the status quo, and explore what it truly means to thrive. So let's get into it. I'm Dr. Santoshi Bilakota.
I'm Dr. Shala Mokbel.
And today we're discussing APPs in medicine. So this is a pretty broad topic, and we'll do more than one episode on it just so we can really explore the topic. But before we start, just to clarify, by APPs we mean advanced practice providers, and we'll define that a little more in this episode because I'm sure there's some people listening that are not doctors in the United States, and I don't think APPs is a concept outside of the United States. But regardless, I want to start off by asking you, Shala, what has your experience been working with APPs?
I have worked with APPs actually during even starting residency. So during our stroke service, we had a APP. She was a nurse practitioner, and she was great. She was a very good nurse practitioner. She ran all the stroke codes. She was very well rounded, and her knowledge was great. And it was interesting because my impression was that she considered herself even sometimes more knowledgeable than the attendings. And even at that time, I thought to myself, it was strange to me. It was odd, but she was great. And then later, when I became an attending, and I work in some of the rural hospitals, and we do have APPs there helping out. Some are very good and they're very well-rounded. They're great at history taking, even the examination, but some need help with assessment and plan, especially in the field of neurology. Neurology is not straightforward all the time. So in some cases are straightforward, like, strokes or encephalopathies, but there are some cases that are more complex, and good APPs are able to ask the questions and show curiosity, but some don't. And some just kind of, I would say, very early stages of medical student. And the problem with some of them that I have is I don't see the growth. It's always kind of the same, and expecting the attending to feed them, things and assessment and plan and things like that. And it's just it becomes very difficult to trust those APPs with with everything. So you have to kind of have a lot of hand holding with them. So good and bad experiences both.
Yeah, I mean, similarly, I think I would say my experience has been variable. And a lot of that has to do with what setting I'm in. So when I was in academic medicine, our APPs were in the stroke service, similar to yourself. And these were really good APPs, APPs who had been nurse practitioners for an extended period of time on the stroke service for over a decade. Not only were they really well equipped to manage the service, but they also knew when to ask for help. They let us lead as second year, third year residents. They never made it seem like they were smarter than us or better than us. We actually had a really good friendship. So I had a good experience with APPs during my training. Also, when I was in the neuro ICU in training, a lot of the acute care nurse practitioners were in there, and they were great to work with. Honestly, they taught me how to put arterial lines in, central lines in. A lot of them came from the background of like cardiothoracic surgery or high level surgical ICU bedside experience. So they knew what to do with drips. So that experience was great. And then I became an attending. And again, at the big academic center that I was at, the APPs, again, were very, very good. But now that I'm doing more community hospital based, I think I am seeing the variability in training. Like you said, some just lack the curiosity. They'll give you some straightforward story, and then you see the patient, and it's like a little different than what they're saying. So I've noticed that when I was at training at academic centers, working in academic centers, there was a really high skill of APP where I did feel like they were an extension of me and I could trust them. But I think now that I'm in smaller settings, that's not quite the case. And that's not to say that community hospitals don't have good APPs. I think that just highlights that you can have such a large spectrum in terms of expertise just within nurse practitioners and PA.
What I have observed, it's the variability also exists in their personalities. So some, are open to feedback, and you can have a trusting relationship with them. But some others sometimes feel that, become defensive if you give them feedback and you try to, educate. Some are very good and great to work with, and some a little bit more difficult, I would say.
I think that's a good way of describing that. So before, we get into it more, as I said, let's define what APPs are because some of the audience might not be practicing in the United States. So when we say APPs, we're referring to advanced practice providers. This is nurse practitioners, physician's assistants, certified registered nurse anesthetists, so CRNAs, clinical nurse specialists, certified nurse midwives. So these all count as advanced practice providers, and their role really is to be an extension of the physician and also to help the physician. Now, that's my understanding as well. There is a difference in the training between physicians and APPs. Now, with physicians, we're training about 12 years, undergrad, med school, residency, fellowship. Let's just say roughly 12 years. It might be more than that, depending. Whereas depending on the APP, you're getting about 6 to 8 years of training. I think that number can be a little bit variable in and of itself because I know a lot of nurses do extended bedside nursing and then they go to nurse practitioner school. Some PAs also do, I think, some form of residency. It's not necessary, but I think it's an option for PA students to do that. Clinical hours are also variable and certifications are also variable. And we'll talk about that because I think what we're seeing more and more is a move away from traditional bedside nursing for X amount of time before you become an APP to now people are just doing their certifications online with zero clinical hours, which I think is concerning. And then, that leads us to the hours of training that physicians in general have about 15,000 hours in training. Again, I think that's variable, depends on the specialty and depends on what kind of practitioner you are. Obviously, if you're a surgeon versus a neurologist, it's going to be different. But for every 15,000 hours that a physician has, a nurse practitioner might have 500 to 1,500 hours. So again, there's a disparity there in terms of length of training and quality. I won't say quality of training in a sense that they're getting less education, but they're getting less hours of clinical education.
Yeah, I agree. And this is huge. The disparity is not just, 1 to 2 years. We're talking about almost half the time, right? Half the time, because we're talking about 4 years of medical school. 4 years of undergrad degree and 4 years of medical school, and then at least 3 years of residency. And you have fellowship on top of it. That's at least one year. So again, we're talking about 12 years after high school. But for APPs, it's about 6 to 8 years. And this is again averages. So it's half of that time. And the clinical hours also, the hours of training, we're talking about 15,000 hours for physicians versus for NPs and APPs. It's not even half. It's much less than that.
Actually, if you compare 1,500 hours to 15,000 hours, that's like, times 10.
1/10. Yeah, 1/10.
Yeah, it's 1/10. And it's on one hand, it's like, okay, so they're not expected to be independent physicians. So I can understand that their hours of training are going to be less. But now we're seeing that over 25 states, I think, have given full practice authority to nurse practitioners. There's about 25 to 27 states that say you can independently practice like a physician can without physician oversight. And I think that is slightly concerning given the fact that, as we can see, the years of training and the hours of training might not be up to par of an independent physician.
And that raises a lot of questions. It goes back
Right.
to our conversations from before. Our physicians needed to have that many years of training to be able to practice, or it's just kind of continuation of cheap labor for many years. You go into residency, it's cheap labor. You work a lot and you get paid a lot less than other people. And then you continue that during your fellowship. So is it really, that training, is it really required, or it's just, again, cheap labor for the society? So because what we see now is nurse practitioners or APPs with half of that are able to fully practice and independently practice without physician oversight. So it raises a lot of concerns and questions that we need to talk about.
That's a really good point, Shala. Actually, I think when physicians think about APPs and look at these numbers, they get really pissed off, right? Like, oh, why, they have such little training. Why can they practice independently? But on the flip side, you have to ask the ACGME people the same thing. Okay, well, if they can go to school for half the amount of time and have 1/10 of the training and practice independently, why the heck am I wasting my time? Right? Like, why am I just cheap labor for these hospitals? It really does raise a lot of important questions.
And some actually, even after you finish your fellowship, some academic centers, they tell you, come join us as a clinical instructor or whatever it is, again, with half of the pay. So there is this norm that continue that cheap labor, continue I will give you a clinical instructor label or addition to your CV, and you'll have more things to put on your CV in addition to your fellowship of 2-3 years of fellowship in this, very prestigious academic center, and then more and more add to your CV, but compensation is the same, and the loan burden is still there. So yeah.
They're just selling you hopes and dreams at one point. I think a little off topic, but one of the most ridiculous things I've ever heard of, I'm sure you have as well, is like this hospitalist fellowship. Have you heard of this?
Oh yeah.
Where
Yes.
after, after you've done your internal medicine training, you do an additional year to learn how to be a hospitalist. Like, come on, man.
Yeah, people sign up for it. Or there was a program. So I did my intern year in one hospital, and then my neurology residency was in another hospital for 3 years. So that first hospital that I did the intern year for, the internal medicine residents had an option to do chief resident year. And the chief resident year would be their 4th year of residency in internal medicine. For the audience to know, internal medicine residency is 3 years. So that was an additional year for folks to just kind of do it as a chief year.
Yeah.
It didn't make sense.
And it doesn't count for anything because it's like,
No.
Okay, you put it on your CV, but like in the real world, who really cares that you did this additional year?
Nobody cares. Yeah.
Nobody cares. It's just free labor. And then one last thing before we get into the topic of why APPs came into fruition. Just one thing, I wanted to add that recently in current events, the emergency medicine programs were thinking of changing from a 3-year residency to a 4-year residency. So that even boggles my mind even more. How are you asking doctors to do more training when we're moving into APPs actually cutting their training further and still independently being able to practice? Like, it just does not make any sense to me.
It does not. Yeah, you're right.
No. So let's talk about why APPs actually became a thing. It started in the 1960s, and this is limited research that I've done on my end. But in the 1960s, the US was facing a shortage of primary care physicians, right? Especially in rural areas. And I think that's still the case currently. So this nurse practitioner program was started around that time. The program was initially started at the University of Colorado. The focus was on family health, disease prevention, and health promotion, all of which makes sense. And then also in 1965, started the PA program to address similar healthcare gaps. Since then, a lot has changed. Now, I will say I do see what they were trying to do with the nurse practitioner and PA programs. I definitely do think even now there is a lack of care in underserved areas, especially for primary care practice, for pediatric practice, for women's health, family health, things like that. So I think it does make sense to have someone who's not a full MD if they can't get a full MD there, but someone who can extend or work as an extender of an MD so we can see more patients and make sure that the preventative practices are there for the community. So I think overall that makes sense. as the APP programs have grown and gained more federal acceptance, then you started having professional organizations dedicated to them in and of themselves. For example, there's the American Academy of Physician Assistants, that's now Physician Associates. That was established in 1968. And over the decades, the APP roles have expanded beyond primary care, right? Now you see advanced providers in surgical care, medical care, hospital, inpatient, outpatient, basically everywhere you see MDs, you'll see APPs.
Right. And there was significant growth in the numbers too. The NPs have increased from pretty much like around 81,000 in the 1990 to over 350,000. So that's a huge increase. Same with the PAs. They have grown from about 40,000 in the year 2000 to over 160,000 today. So that's why they lobby better for themselves. They're able to grant to be granted full practice authority, I think, because now there are more of them that are affected by the changes. And then COVID-19 was another catalyst because there was a huge shortage of physicians during that time, especially in emergency measures. So that's why there were more APPs that were allowed to practice independently in certain states during that time. So yeah, there is a lot going on with the APP world that a lot of physicians might not know, and I definitely did not know before I started doing my research and started talking to my APP friends. But as you said, it makes sense how it started. It made sense that to address the physician shortages in underserved areas and in rural areas especially for preventive medicine and primary care, because again, if they need help, then they can ask help of consultants, for example, and surgeons and things like that. But I think, and we'll talk about the cons. I think what becomes problematic is when they're practicing beyond their scope.
I think just going back to what you said about how they've grown so much in number, like exponentially so right.
Yeah.
And we've talked in other episodes that there's power in collective advocacy. Like you're not going to change a system unless you come together. And one thing I've seen across APPs, be it nurse practitioners or PAs, is they definitely support and advocate for each other much strongly than physicians do. Physicians, man, I'll tell you, I don't. We tend to be our own worst enemies. We don't support each other as well as APPs do. And I know that's a generalizing statement I'm making, but it's my observation. And I think because they do support each other, they do unionize, they collectively have gotten to a point now where they're driving a lot of change. Like we said, there's more states, and there'll continue to be more states, I think, that will grant full practice authority for nurse practitioners. We mentioned that they're expanding into specialty care. So it's no longer taking care of a grandpa in a rural setting. Now they're doing cardiothoracic surgery, they're doing aesthetics, they're doing Botox down the street, they're in the ICU. So a lot of the times, the healthcare systems have adapted around APPs, and I think because they have a collective voice, they advocate, and they're very good at bargaining for their needs.
That's a great point. Also, it's reflected in the compensation trends because for example, 2024, the median total cash compensation for APPs saw the highest year-to-year increase in the surgical specialties, and then also followed by primary care, followed by other medical specialties. But we see the reimbursements for physician have decreased. So it's kind of, I was thinking about this, it's kind of an inverse relationship between physician, a future of physicians and future of APPs. It's like, total opposite.
Yeah, but it also makes you wonder, like, how are they able to advocate so well for themselves? If anything, I think APPs teach us that we can make this also happen for ourselves. We have no one to blame but ourselves.
Yeah.
I see a lot of physicians are like mad about APPs doing what they can, but I say, hey, they're able to make that happen and they're working for it. Who am I to hate on that? The reality is we're not advocating like that for ourselves. So who is to blame except for ourselves?
You're right. Exactly. And that's why we're doing this podcast. I hope that things change.
Exactly. And I do hope things change as well, because I think if they can do it, I mean, certainly we can advocate for more compensation for ourselves. We can advocate for better working environments for ourselves as well. So of productivity, we also see that APPs are becoming more and more productive, and institutions are actually able to track individual performances and productivities of APPs, to a point where I think some hospitalists are, or some hospitals, I'm sorry, are hiring APPs, not just to offset physician shortages, but also, in a sense, it seems like a better financial decision for hospitals to hire APPs, because if they're doing similar work with similar reimbursements, but you have to still pay them less than a physician, that sounds like a good deal if I'm a CEO of a hospital.
Instead of having like 5 physicians, it's better to have, for them, it's more cost effective to have 2 physicians and 2 APPs. So definitely it's more cost effective. And unfortunately, some of these hospital administrators, they don't know about the quality of care. They don't understand the quality of care, and they don't understand, some patients are complex and and some APPs need to have physician oversight. It's impossible to have half the training or half the hours and be able to see all the complexities that go into more specialties, like the neurology or cardiology, or other specialties like rheumatology. So there is something to the physician oversight.
Definitely needed. I would even argue to say, like, how are you teaching someone who's never done a neurology residency how to be a neurologist? You know what I mean? It just doesn't make sense that you get your degree and then all of a sudden you're put in this position where you have to do subspecialty work. I mean, it's not fair to them either, you know? But with that said, I think there used to be standards. Not that there isn't anymore, but we've spoken to APPs who were bedside nurses for an extended period of time and then took their APP training very, very seriously. And I think those APPs, and I worked with some of them, they're like a pleasure to work with because they know what they're doing, they don't overstep, they make safe decisions. But in our next episode, where we'll talk more about the future of where APPs are going, I think we can talk more about how there's been a lot of push for this online training, because a lot of nurses, I mean, even on social media that I see, they don't want to do bedside, and I can understand that. So what they'll do is they'll go to these online programs with limited clinical training, right? And they're hoping to be either like a psych nurse practitioner working remotely, or some kind of remote NP position, or even in person, doesn't matter. But the point is, the training that's already less is now becoming like zero.
Right. Can you imagine becoming a physician over an online program? It's it's a joke, right?
I
Without
mean,
the training and
oh gosh.
everything. Not my medical school, but dental school. I know that one of my friends during his dental school, they didn't have mandatory attendance, and he basically did most of his courses online. But then he still had to go for the clinical, right? You still have to have the clinical rotations. So yeah, no, I really don't think that those online programs are going to be good for patient care.
And I think, I went to a Caribbean med school. I'm vocal about that. So there's concerns of quality of doctors coming from there as well, because they also see those as degree mills. And I totally understand that. But I think the one thing that differentiates that situation from this is that clinical is still a mandatory requirement. We still have to do the same clinicals that everyone else has to. And you still have to go through that residency training to practice. I mean, there are a lot of unmatched international medical graduates. And I've also heard of them. This sounds really ridiculous, but imagine being an international medical graduate who didn't match, who can't practice independently, right? And then you go to PA school, or you become an RN, and then you go to NP school, and now you can practice independently. Like, what sense does that make? But I've heard of those stories too.
Yeah, yeah. I've heard those stories as well. There's a lot to talk about, and I think we can do another episode on this. What do you think?
Yeah, I think we should wrap this one up, but I think in the next episode, let's focus on what we see the future to be of APPs, including scope of practice and regulation. To be fair, we'll also talk about the pros as well as the cons of having APPs and APP integration and things that I think we should be concerned about as we're moving more and more into APPs being integrated into the healthcare system.
Definitely. Thanks for tuning in to Be Empowered, the podcast. If you enjoyed this conversation, don't forget to subscribe, leave a review, and share with someone who needs this. Stay strong, stay empowered, and we'll see you next time.